Okay, all right. Well, thank you so much for inviting me to give this talk. And I'll be speaking on the radiation dose optimization in patients who are having CT. So when we talk about the steps in reducing or minimizing the radiation dose from CT, we have to take a stepwise approach in which we acknowledge the different role players, look at the justification or the appropriateness of the exam, know the CT scanner, make protocols that are based on the indications or the clinical reasons, make sure that we are not scanning the patients too many times, so scan phases. And then finally, we have to look at the scan parameters to make sure that they are optimally applied, monitor these radiation doses, and when there are quality issues, we should not be shy of taking the blame and fixing those issues. So there are lots of people that are involved in making good protocols, but perhaps the most important player is the patient. Why? Because we need a degree of cooperation from the patient so that while we are scanning, when we give the instructions to the patients to lie still, hold their breath, make sure that the position of the arms is optimal if they can raise their arms, for example, for patients who are getting a chest and abdomen CT. And of course, we have to make sure that we pay attention to the centering of the patient while doing the CT scan. So all of these things mean that the technologist has to speak with the patient and has to pay attention to all these details as they are positioning or placing the patient on the table. So the other key players, of course, in the CT is the referring physician, the person who actually would refer the patient to get a CT exam. Radiologists have a big play in making sure that the protocols and the radiation doses are optimal. CT technologists, by paying attention to the details of instructing the patient to lie still, follow the breathing instructions, centering it properly, getting a good scout, and then applying and choosing the right CT protocol, has a lot of role in optimization of dose. And then finally, not the least, but also very important, is the role of medical physicists in this to ensure that the protocols are well selected, scan parameters are optimally applied, and then the doses are monitored and are below the recommended guidelines. How about the physicians? Well, the physicians and the radiologist have to work together to make sure that the exams are justified and done for the correct reason. So it doesn't mean that the relationship always has to be a relationship of love. Sometimes we can bark at each other to make sure that the exams are done, first of all, with proper clinical information related to the radiology department so that they can choose the right protocol. Many times it happens that the departments have only one or two protocols. And one of the reasons they say, well, we scan everybody with the same protocol with 2 or 3 or 4 phases, because we do not get any information from the referring physician about the clinical indication. And that is something that the radiologist has to take up with the referring physicians or the hospital administration, that they should get proper reason as to why the exam is being done. In our hospital, we follow the decision support system or the online order entry for the radiology exam, in which the physicians log in and they select or they insert the patient's medical record number, the patient's age and gender pop up, and then they select from the list of signs and symptoms, what is the patient's complaint. Then they select what test they want to do. For example, a head CT. And the system then gives information back to the physician whether or not this exam is going to add meaningful information. For example, in this patient, if they selected dementia and a head CT, the system will tell them, well, this is unlikely to give a lot of useful information, so low utility exam. And then the system would recommend that the alternative test to consider would be MRI or PET in this patient. Right? And this is based on the American College of Radiology appropriateness criteria. There are lots of other entities, including in Europe, where they have done a similar type of work, and they also help you decide whether or not for a given sign, symptom, or patient disease, a test that the physician is ordering is appropriate or not. So not just in the US and in our institution, but also in other places, you can have access to such kind of information and then can build your own either online system, or at the very least have some kind of a form where the physicians can check, well, this is the indication, and then you can decide what protocol to be used once the justification is set. The advantage of having this kind of a system where you assess the justification is that, if you see this chart from our hospital in GH and you see the bottom chart from Mayo Clinic, we use the similar system, and then we can see that there is a deflection of this line, basically, which actually tells us that, the CT was growing at a steady rate of about 10% every year. And then once this system was applied, the growth in CT actually stalled, and you can even argue that it may have fallen down a bit. Okay. The same thing happened at the Mayo Clinic as well. And not only that, but if you look at this line with the green dots, you can actually see that this is the line of MR, the number of exams we did for MR. And not only CT became flat or came down a bit, even MR, where there was over ordering, it also came down. So there can be some decrease in the number of exams that are not done for the right reason with such oversight. Now, one of the things that I mentioned that people, complain about is that, well, I use only one protocol because I get no clinical information and I have no electronic medical records. Well, if that is the case, we do have to talk to the referring physicians. The referring physician obviously comes from a position of strength. So therefore, it's important to, while we maintain our relationship, to not feel shy, to basically come up with some kind of a form, some kind of an online system where we educate them, where we provide them with a list of common indications so that they can just select a box. And of course, we have to make sure that the boxes are correctly selected for proper clinical indication. And, we also ask in our system that the physicians provide their phone number or a pager number or something, so that in case we have a doubt, we can actually ask them questions. And in our hospital, we have our residents whose job, the first thing in the morning is to go through all the list of exams that are scheduled to make sure that the proper protocol has been selected and we have the required clinical indication. Because the clinical indications are tied to the specific CT protocol, the radiation dose is different for every protocol. As a result, we have to put in a little bit of extra work. And we typically ask our residents, and sometimes the technologists might have to do that and then consult with the radiologist, but most often, more than 95% of the time, it's just the residents, whose job is first thing in the morning to take care of this. Now, apart from the indication, we do have to know about the capability of the CT scanner that we have, how many slices do we have in terms of the CT scanner. So we know the capabilities of our scanner and can schedule the patient to an appropriate scanner, whether it be a pediatric CT where you want to put the child on a faster scanner, or a cardiac CT or a vascular exam where you want to put the patient on a scanner that has more number of slices. Of course, because we have 18 CT scanners in our institution, we do have to take that into account. But if you have 1 or 2 or 4, that job is a bit easier. So, I'm sorry for this mess up, but, when we talk about the CT scanner, we do have to know how many how many detector rows we have, what is the rotation time, the fastest rotation time that we have got, what is the capability of the gantry table to hold patient of large dimension. So all of these details, we should know when we have a scanner. Apart from that, different scanners have different dose optimization techniques, such as techniques for automatically modulating the tube current, automatically selecting the right kilovoltage or tube potential, and then different cardiac CT capabilities like prospective triggering or retrospective gating of exam with dose modulation, which is based on ECG rather than the size of the patient in a more typical dose modulation technique. So once we know the capabilities of our scanners, it is now the time for the radiologist and the technologist, with or without the medical physicist, to actually make some key scan protocol for every body region. So I recommend that we should have at least 5 different protocols for every body region, right? And we often have many more than that, but that is something that is a minimum requirement so that we can tailor the doses according to the indication. In the chest, for example, routine chest, that would be around 80 to 90% of the entire volume of the CT of the chest that we are going to do. In the routine also, you'll have one with contrast and one without contrast. And then the important protocol for the chest would be, of course, CT pulmonary angiogram or for pulmonary embolism, for lung nodule follow-up. Lung cancer screening has become a very common exam now. A diffuse lung disease, or what is called as the high-res CT of the chest. And tracheal or the airway protocol is another one that we need to make, because these patients get inspiration and expiration phase images. And then also, as compared to a routine chest, the airway protocol exam starts from the neck, okay? In the inspiration, and then in the expiration, it starts from the neck, but it stops at the carina, okay? So we adjust the scan length, we adjust the scan parameters and the scan phases depending on the clinical indication. Can you still hear me? Can you still hear me? Oh, perfect. Okay, I just wanted to make sure. Okay, thank you. So how do we do these indication-based protocols? So the first thing is that we have to know the common clinical indications that we are going to get from the physicians, okay? So as I said, we discussed about the chest in the previous slide. So for routine chest with IV contrast, routine chest without contrast, diffuse lung disease, lung nodule follow-up, lung cancer screening, CT pulmonary angiogram. So it's not just enough to have the names of the protocol. It's important to fill the information as to when will we use which protocol. So the technologist and, the radiologist and the residents know that, well, if the indication is lung cancer, I'm going to use this protocol. If the indication is that this patient had a lung nodule on the prior exam, I'm going to apply the lung nodule follow-up, right? And the other thing that these protocols should have is how many series or how many times are we going to image this patient? Whether it's going to be an inspiration, which is the most amount of CT scanners, or is it going to be just a breath hold? A lot of time we hear this complaint that the CT pulmonary angiogram is not of good quality. And one of the reasons is that, we set all the scan parameters right, but we forget to look at the breathing instruction, that compared to the routine chest, where we ask the patient to take a deep breath in and hold his or her breath, for CT pulmonary angiogram, we ask the patients to keep breathing normally and then just stop breathing. They are instructed not to take a deep breath before they hold their breath. Okay, so that's the key difference, right? So all of those details, have to be in the scan protocols. And that's why it's a good idea to have a written copy or an online copy where all of these things are tackled. And the reason also we need different protocols for, let's say, just the chest is that if you're looking for something that is really fine, let's say ground glass opacities or some septal thickening, then, we perhaps need a little bit higher dose. But if you're looking at lung nodule, for example, right, as you can see in these images, it doesn't really matter whether you are at 13 milligray at 240 MAS or you are at 20 MAS at 1.3 milligray CTDI, you can still see the nodule. Very difficult to miss it, right? Even many of the ground glass opacities, for example, here, you can make up, okay? But obviously, if you're looking at very subtle reticulations, for example, with the high-res CT of the chest, you need a bit of a higher dose. Now, if the idea is to look at the mediastinum or the soft tissues along with the lung, you also need a bit of a higher dose. So that's why the routine chest will have higher dose as compared to the lung nodule protocol. For example, if you look at this mass in the subcarinal region, and you can see that there is complete opacification of this right lower lobar bronchus, right? And this is something that you see at 13 milligrade. As you drop the dose, you can still see that bronchus, and even at 7, you can see it. But as you come to the doses that we were operating on for lung nodule, you can see that the bronchial wall and that soft tissue mass begin to disappear, right? Or get affected by the noise in the image, right? We can still see the pulmonary opacities and all that fairly well. But for the mediastinum and soft tissue, you don't want to be as low as the lung nodule. Otherwise, you will start losing details. And this is another reason why, based on the location of the finding or the type of clinical indication, it's important to build our radiation dose for optimization. A number of scan phases is another very important aspect, whether it's in the chest or whether it's in the abdomen. For the chest, for example, most of the routine chest CTs, including the pulmonary embolism, is one phase exam, either with contrast or without contrast. The two protocols that may require additional images, for example, are the high-res CT for diffuse lung disease or pulmonary fibrosis, and the airway protocol or the tracheal protocol, where we do have to acquire additional low-dose expiration phase images, particularly if it's a baseline exam, especially if we are looking for air trapping or for the collapsibility of the trachea. Otherwise, if it's just for the evaluation of tracheal stenosis, you do not require the low dose, kind of the expiration phase images. For the abdomen, it's the same thing, most of the routine abdomens, which is almost, I would say about 3/4 of the exam in our institution, is just one phase only. Most patients would get portal venous phase straight, and that would be the only thing that they would get unless they have a focal lesion in the liver or other places, in which case they will get a delayed phase. The liver protocol, we skip the non-contrast, go straight to the arterial, only through the liver. Portal venous phase goes through the entire abdomen pelvis, and then delayed phase goes through the lesion and not really through the entire abdomen. So the technologists do have to look at the images once they are acquired to make sure that A, they are of sufficient quality, and B, if there is a lesion that needs a delayed phase, they can immediately plan and do it. Nothing is by default, right? The delayed phase is not by default that every single patient is going to get it. Okay, it's only when you see something and only through the place where you see something. So this is just an example of one of the places where you can see that they have, they have done a few chest CTs, and most of these chest CTs, as you can see, there is a scout, a non-contrast, and a contrast, right? Now, if you look at their CTDI volume 7 and the DLP around 274, they both look fine. But the point of showing this is that, when you have good scan parameters, their pitch seems okay. They are not using 140 kV. Their rotation time seems okay. Their reconstructed slice thickness is fine, right? But the problem here is because they are scanning the patient twice for a chest, which is not needed, basically, non-contrast and contrast, they are doubling the doses as compared to what many other places which have good practices use, which is just one phase for most of the routine chest CTs. This is just the example from the same site. As you can see, non-contrast phase for the chest, arterial phase for the chest, and then you have the delayed phase. And here, as you can see here, you're using 100 kV for each phase. So something is going right. This is a really big patient. As you can see, you're not able to cover the entire chest wall in this very large field of view study, and they're using dose modulation. You can see that by noise index 27, so fairly high noise index. So they are asking the scanner to optimize dose. But the fact that they basically are doing 3-phase means that whatever dose optimization they did by choosing the right scan parameters, the radiologists and the technologists actually just literally destroyed it because they scanned the patient 3 times, which was unnecessary. And incidentally, this patient had nothing, basically, negative exam. So, these are the things that lead to, poor dose optimization. If you have too many scan series that you're acquiring. From the same institution, I also captured some of their dose information record. And as you can see here, for the abdomen CT, they have a CTDI of 12, which is not too bad if the patient is of decent size, right? And this exam has 13, okay? So 2 separate exams, but one of the things that I noticed was that all routine abdomens in their institution had a non-contrast arterial phase, venous phase, and the delayed phase. If you pay attention to this last row, you can see that the CTDI volume is similar, but the DLP is a third of the other phases. So what did they do? They actually scanned just through the liver, most likely. But the point is that if you're going to scan 4 times every patient of routine abdomen, no matter what amount of dose optimization you do, these patients are going to get a DLP of 3000, right? And which is 40 millisievert or higher dose, basically. So that's how even a good medical physicist or a good technologist, who have done their job to make sure that the scan length is appropriate, the scan parameters are okay, their effort can just go down the drain if we don't pay attention to how many times we are scanning every patient. Now, obviously, if this was a liver mass evaluation or a renal mass and all that, this would be okay. But this is just a routine abdomen CT. With somebody who comes with abdominal pain, this is not appropriate. The other thing that is important is the scan range. How long are we going to scan for? Because the longer the area that we scan, obviously, the DLP goes up, the scan volume goes up, and the radiation dose goes up. So it's important to tailor that. For example, for routine chest, we would go up to the adrenals. For the lung nodule follow-up or for pulmonary embolism protocol, we will stop at the lung basis, the lungs only. There's no need to go down to the adrenals, right? And these things, make a difference in dose because we are scanning less area of the chest or the less area of the patient or volume. For the abdomen, similar story, right? That for your routine abdomen, you would scan from the dome of the liver or the top of the liver to the pubic symphysis. Some people go to the ischial tuberosity, that's fine. Delays are only through the lesions. And then for kidney stone protocol or CT urography, we start scanning from the top of the kidneys and go to the symphysis pubis. And then adrenals are only scanned from, let's say, T11 to L2 vertebral body, because these are protocols where we already have seen a lesion on a prior CT, and we are just doing for characterization. So there's no need to actually scan the patient 3 times through the entire abdomen. Instead, you just scan over that short scan length 3 times, and the dose will be less than 1 time of the entire abdomen. So that's how you can actually very cleverly make sure that you are doing justice to every patient with the right protocol, right approach. Setting the scan factors involves a teamwork where you involve the radiologist who has to tell you, well, which is the protocol where I can accept a little bit more noisier images, right? A little bit lower dose images or a lot lower dose images, for example, for lung nodule. Radiographer has a very important role because they have to make sure that they are not over scanning, choosing too wide of a coverage. Medical physicists can help and select the right parameters for a given indication based on the input that they get from the technologist or the radiologist. And their role is also like a watchdog. If they see that the doses associated with the particular scanner or a particular protocol is too high, they should reach out to the radiologist and the radiographer, talk to them, inform them, and then take steps or help take steps to make sure that the doses come right where they should be, that is below the recommended levels. So KV or tube potential is one of the most important parameter. Most of the chest CTs, if you have a scanner that is 16 slice or higher, should be around 100 kV. And when I say most, I would say the patients who are less than 80 kilograms, certainly they can be scanned at 100 kV or less. Okay. For the abdomen, 120 kV is still something that we most commonly use, although with the newer scanners with higher tube current potential, higher tube current abilities, you can scan many of your routine abdomens also at 100 kV. But for most abdomen CTs, still 120 kV. For chest, I think 100 kV is better because A, it helps optimize dose, B, it helps make the contrast appear brighter. So if you're doing post-contrast chest CT, it's very useful to be at 100 kV, or in a patient who's less than 50 kilogram, that 50-80 rule, you can actually even get away with 80 kV. But at the very least, 100 kV is what I recommend for most chest CTs, unless you have a patient who's like, 80, 90 or 100 kilogram and is not a long patient, but a short patient. So somewhat a patient that I regard as a big patient regionally. Some scanners have automatic tube potential selection technique. And in these scanners, you basically acquire your scout or localizer. You basically set up a reference kV value. For example, in this case, you select 100 kV for chest, 120 for the routine. At what is the clinical indication, for example, on this scale here? So if you took this bar and this ball and you made it 1, it tells the scanner this is a non-contrast exam, so that the scanner would try to reduce the tube current rather than the tube potential more, to reduce and optimize the dose while keeping the quality. But if you slit this ball right to 11 or 12, you tell the scanner that this is a post-contrast CT angiography-like study, in which case the scanner would actually try to keep or select the lowest kV and then choose a little bit higher MA so that the dose is optimized, A, and then B, the contrast is maximized in the image, B, and that sufficient image quality can thus be obtained. So these are very creative, very nice solutions. So if you have the right scanner with this technique, I strongly recommend using it. But the key to this is selecting this bar. So you only have to set it up once for a given protocol. For example, for all CT angio protocol, it will always be at 11 or 12. So it's not that you have to remember to do this on every patient. You just have to set it once for a protocol, and then the scanner will do its magic and choose the right kV. Both GE and Siemens and Toshiba, they all have this technique. It goes by care kV or kV assist or sure kV. Right? But the key is to select the right reference kV and then to set the bar at the right point so that the scanner can, based on the patient size, select the right kV and give you the best quality. Similar is tube current modulation, which actually would look at the scout or the localizer and then will automatically adjust the tube current and radiation dose based on what you set as the reference MAS or the noise index or the image quality. So you do have to remember that these techniques will only work as good or as bad as the parameter that you fed in. If you select a very high MAS or noise index or a reference quality, it will not do any dose modulation for indication. It will only do dose modulation for the size of the patient. Remember, the intent for us is to set the quality in the scanner for clinical indication. The scanner will do its magic for different size patients based on the automatic kV selection or based on what you selected as tube potential and based on what you selected as the criteria for tube current modulation. So your job is to make sure that those things are modified for the clinical indication and the need for image quality, and then the scanner will take care of the patient size. That's the key thing here, right? The scanner cannot adjust the dose based on clinical indication unless you save those protocols, unless you accept those protocols. The beam collimation, this is more important on the scanners that are 64 slice or under, because most of the newer scanners have the same detector kind of profile. You can select a narrow or a wide beam, and that selection is based on what you're imaging. If you're doing small body parts like a head CT, you should select a narrow beam so that you can avoid some of the artifacts, get good quality, and be dose efficient. If you're scanning longer body parts like a chest or an abdomen or the whole legs, you do have to A, finish the scan in reasonable time so you avoid motion, and then B, you have to be dose efficient so you choose the wider beam. On the older scanners, you have to remember that wider beam means thicker slices. So if you really need thin slices, like for high-res CT of the chest, you may have to choose a narrow beam, which means that the radiation dose will be higher. It's going to take longer to finish the scan, so you have to adjust your rotation time so that it's not slow. So all of these things, is a tricky interplay of scan parameters that you have to be on the scanner when you make these things, at least for the first time. Once you get a hang of how the scan parameters interact with each other, it's very easy and straightforward. Slice thickness is important for some scanners. Why? Because some scanners, depending on what you choose as your slice thickness, will change the radiation dose. So when we mean the slice thickness, we don't talk about the retrospective recon. It's the first prospective slice thickness that the scanner is going to see. For example, on the GE and the Toshiba scanners, if you choose the thinner slice versus thicker slice, the radiation dose for the thinner slices will be higher. On the Siemens and the Philips, it doesn't really matter what you choose. This dose does not vary by the slice thickness that you set. And then the slice thickness has to be chosen. For example, for the chest, it's recommended that one of your slice thickness be close to 1 millimeter, 1 to 1.5 millimeter, or even less. For the soft tissues in the chest, 3 millimeter is more optimal, right? We do not use 5 millimeter for the chest now. Okay. The only place where I would sometimes apply it is the patient was really big and we already have done a scan and it's too noisy. We would go and make the slices thicker, and that sometimes helps. 5 millimeter is still very commonly used for abdominal CT, although many places are now moving to 3 millimeter, but you have to be very careful when you do that because the noise goes up as the slice thickness goes down. For the lungs, we don't really care about the noise as much. So that's why we can afford to be thinner in the slices and still be lower on the radiation dose. Iterative reconstruction, I recommend using it if you have these techniques available on your scanner. Now, some people complain, well, do the images get a little blurred? The answer is that if you use too powerful of an iterative reconstruction or very high strength iterative reconstruction, then yes, you can lose some spatial resolution and things can get blurred or pixelated. That's why it's very important that you get the sweet spot right. Okay, so we typically recommend that you use a strength of 2 or 3 or 20 to 30%. That's the starting point. As you get used to it, you get comfortable with it, you can increase that strength. Not too much. I would not recommend you going beyond 50% or beyond a setting of 3, for example, because at that point, the radiologists start complaining, and at that point, there is some change in the image texture. When you do apply these techniques, we have felt that you are able to reduce your tube current either by about 20 to 30%, or you can actually apply more low tube potential or low kV exam in your practice and not suffer from increased noise at low radiation dose. So I recommend these techniques. These have been shown to be effective. And I would say that 99% of the papers published document dose reduction and improved image quality with this as compared to filtered back projection. Some places who do document some decrease in image quality is because they have been too aggressive and go for very high strength, which I do not recommend. Here's just an example to show how the one type of iterative reconstruction can actually improve the quality of the exam. Here you can see that the patient has been scanned 3 times at 3 different kV and the dose combination, and as compared to the filtered back projection, you can see a decrease in the noise. The decrease in the noise also varies by the strength of the iterative reconstruction. For example, this is a strong setting, right, as compared to a standard setting. And you can see that these images in the top row have lower noise as compared to the images in the bottom row. And this is how, depending on what you set as a strength of the reconstruction technique, you can actually have different type of noise. And the point is that you can see the CTDI is less than 1 for all of these images, but they're all acceptable. And one of the reasons for that is that we've applied the iterative reconstruction technique. Monitoring radiation dose is also important, and medical physicists here are most important, in terms of making sure that we have some kind of a monitoring system in place. If we have dose tracking system or software, that's the best, because it automatically does that for you. Otherwise, one has to collect the doses, and the old way, the manual way of actually writing them down and then looking up on the internet to see which doses are higher than the recommended levels. So in our institution, we would have at least a quarterly dose review in which we basically pull up what are the exams that exceeded the recommended dose levels. So every single patient, basically, because we have the dose tracking system, the software is able to identify these patients who exceeded the threshold. And, despite having good practices, you can still see that we have quite a bit of a list. This is from 2016, a little bit dated, but the list still comes up where we have doses that exceed the recommended levels, right? Sometime, and then for all of these exams, the medical physicists and the senior technologists will sit together and evaluate, why did this happen? How can this be fixed going forward? For example, this patient for head CT was scanned at 109. The recommended level is 70 for the head. So he did exceed by almost 50% the dose level. Why did that happen? Well, that happened because we applied tube current modulation for the head CT, and the patient's shoulders were very large and were in the scan topogram or the scout. As a result, the dose went very high. So the fix for this solution is that when you have the shoulder popping up into the head or neck, into the head CT, you should just use the fixed tube current and not apply dose modulation. Okay, so these are kind of things that they have to look at, right? In this case, the CTDI was 95. This was a very large person, and the neck had to be scanned too. So therefore, there was really no need to adjust this, because the reference levels are for standard size patients, and sometimes for patients who are large or larger than the others, you have to apply higher dose. But the point is to make sure that we understand that we don't just do CT for just getting the information. We also give radiation, and that has to be monitored. So I got some data from Ukraine on COVID, basically. They had scanned some patients who had suspected or known COVID-19 pneumonia. And I looked at some of the protocols from 2 sites. One of the site, which basically had a 16-slice scanner. Actually, you can see that their median CTDI was 6 milligray for the chest. Very good. They applied 100 kV. Good job. They applied dose modulation. Excellent. They applied a low reference NES. Very well done. They applied the right pitch of about 1 or higher, which is what is recommended. And then they had 0.5 second rotation time. They had 0.75 millimeter slice thickness. Very good. This place didn't even have iterative reconstruction. But you can see 6 milligray as opposed to the other place, which had a 64 slice scanner, 120 kV, right? And then a pitch of 0.2, which I don't think was correctly stated, so misstated, okay, right? They applied the iterative reconstruction, and despite all of these things, they did apply the automatic exposure control technique, but I don't think they supplied the right reference quality. And as a result, you can see that the dose is almost twice as high. This was basically median in 10 patients from site 1, median in 10 patients from site 2, which had a better scanner, but almost double the dose. Okay, so not a very correct policy, right? If you look at their pulmonary embolism protocol, this is where both the scanners got the thumbs down, because the site A did arterial and venous phase, not necessary. The site B for pulmonary embolism did non-contrast and arterial and venous, completely unnecessary, right? So you can see here, right scan parameter, even if you have a loader scanner, can actually give you better doses or lower doses. as compared to the wrong scan protocols, even with a better scanner. So therefore, we have good technological innovation, great scanners, faster scanners, good image quality, but if we don't do our job right, don't set the right scan protocols, then the doses can be really high, and that's not helpful to anybody. So finally, I'd like to conclude with this slide. One thing that is important when we make the scan protocol is that we make it separately for different body regions, because some body regions like chest can have lower doses as compared to some other body regions like the abdomen. Then we have to make sure that we have indication-specific scan protocols. We can have the best scanner in the world with like 640 slices or 512 slices. If we don't have clinical indication-based protocols, it's not going to do its job properly. Once you have the right indication-specific protocols, we will let the scanner do its job to decide what the radiation dose should be for a given patient size. You may need to adjust it for a very large person, like you may need to slow down the rotation time and change the detector configuration for a very large person. But for most patients, the automatic techniques should work and will work very well. And then basically when we do get quality issues and there are complaints about the quality because the dose is too low, we should remember that we have some things that we can do. We can make the slices thicker. We can increase the strength of iterative reconstruction. We can also, if we have the raw data, in addition to the above two, we can also adjust the reconstruction kernel or the setting, make it more softer or more standard instead of very sharp. And I think that is about all I have. Thank you very much.